Vein of lab, large draining vein, connecting the superficial middle vein and the transverse sinus. Vein of Trillard, smaller, usually, vein, connecting the superficial middle vein and sagittal sinus. (136). Section 2. Volume I edema. Monro-Kelly hypothesis. The Monro-Kelly hypothesis is the idea that the head is a closed shell, and that the three major components, 1. Brain, 2. Blood, both arterial and venous, and 3. CSF, are in a state of dynamic equilibrium. As the volume of one goes up, the volume of another must go down. Normal situation leaking CSF, venous blood expands to compensate. Intracranial hypertension, venous sinuses compress. Intracranial hypertension, if you are leaking CSF, this will decrease the overall fixed volume, the volume of venous blood will increase to maintain the equilibrium. The result is meningeal engorgement, enhancement, distension of the dural venous sinuses, prominence of the intracranial vessels and engorgement of the pituitary. The development of subdural hematoma and hygromas is also a classic look, again, compensating for lost volume. Idiopathic intracranial hypertension, pseudotumor cerebri classic scenario of a fat middle-aged woman with a headache. Etiology is not well understood, making too much CSF, or not absorbing it correctly. It has a lot of associations, hypothyroid, Cushing's, vitamin A toxicity. The findings follow the equilibrium idea. With increased CSF the ventricles become slit-like, the pituitary shrinks, partially empty sella, and the venous sinuses appear compressed. You can also have the appearance of vertical tortuosity of the optic nerves and flattening of the posterior sclera. 137. Obstructive hydrocephalus. Communicating, this is an obstruction at the level of villi I granulation, blocking reabsorption. All the ventricles will be dilated, 25% of the time the fourth ventricle is normal. There are four main causes. 1. Normal pressure hydrocephalus, it's not well understood, and idiopathic. The buzz phrase is ventricular size out of proportion to atrophy. The frontal and temporal horns of the lateral ventricles are the most affected. Upward bowing of the corpus callosum is another catchphrase. On MRI you may see transependymal flow and slash or a flow void in the aqueduct and YD ventricle. The step 1 trivia is wet, wacky, and wobbly, describing the clinical triad of urinary incontinence, confusion, and ataxia. This is treated with surgical shunting. 2. Blood, 3. Pus, and 4. Cancer, anything that plugs up the villi, the three most common causes being SAH, meningitis, and carcinoma 2 meningitis. Non-obstructive. This is sort of a trick question, with the only answer being something that produces CSF. The only answer you need to know is choroid plexus papilloma, discussed in detail in the tumor section. Quiz, LS transpendymal flow seem more with acute hydrocephalus or chronic hydrocephalus? Answer, acute. 138. Edema. Cytotoxic, this type of edema can be thought about as intracellular swelling, secondary to malfunction of the Na/K pump. It tends to favor the gray matter, and looks like loss of the gray-white differentiation. This is classically seen with stroke or trauma, and is why early signs of stroke involve loss of the GMWM interface. Vasogenic, this type of edema is extracellular, secondary to disruption of the blood-brain barrier. It looks like edema tracking through the white matter, which is less tightly packed than the gray matter. This is classically seen with tumor and infection. You can also see this type of edema as a late stage of cerebral ischemia. A response to steroids is characteristic of vasogenic edema. Dash a dash dash. Dash a dash a dash dash a dash a dash. Underscore. Dash a dash a dash a dash dot comma dash dash a dash dash a dash dash a dash a dash a dash dash. Dash dash a dash a dash a dash a dash a dash 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 a dash dash. Cytotoxic edema, L. Vasogenic edema. Failed Na/K pump, BBB intact, I increased capillary permeability. J. BBB not intact. Dash dash dash. Dash. Dash dash a dash a dash 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 a dash dash. Dash dash a dash a dash a dash a dash a dash a dash 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 a dash. Classic equals leukemia, early. Classic equals tumor, infection, leukemia, late. Dash a dash dash a dash a dash a dash dash a dash a dash a dash a dash dash a dash a dash. To compensate. Intracranial hypertension, venous sinuses compress. Intracranial hypertension. Hypotension. If you are leaking CSF, this will decrease the overall fixed volume. The volume of venous blood will increase to maintain the equilibrium. The result is meningeal engorgement, enhancement, distension of the dural venous sinuses, prominence of the intracranial vessels, and engorgement of the pituitary. The development of subdural hematoma and hygromas is also a classic look, again, compensating for lost volume. Idiopathic intracranial hypertension, pseudotumor cerebri classic scenario of a fat middle-aged woman with a headache. Etiology is not well understood, making too much CSF or not absorbing it correctly. It has a lot of associations, hypothyroid, Cushing's, vitamin A toxicity. The findings follow the equilibrium idea. With increased CSF, the ventricles become slit-like, the pituitary shrinks, partially empty sella, and the venous sinuses appear compressed. You can also have the appearance of vertical tortuosity of the optic nerves and flattening of the posterior sclera. 137. Obstructive hydrocephalus. Hydrocephalus. Communicating, this is an obstruction at the level of villi granulation, blocking reabsorption. All the ventricles will be dilated, 25% of the time the fourth ventricle is normal. There are 4 main causes. 1. Normal pressure hydrocephalus, it's not well understood, and idiopathic. The buzz phrase is ventricular size out of proportion to atrophy. The frontal and temporal horns of the lateral ventricles are the most affected. Upward bowing of the corpus callosum is another catchphrase. On MRI you may see transependymal flow and slash or a flow void in the aqueduct and YD ventricle. Ventricle. The step 1 trivia is wet, wacky, and wobbly, describing the clinical triad of urinary incontinence, confusion, and ataxia. This is treated with surgical shunting. 2. Blood, 3. Pus, and 4. Cancer, anything that plugs up the villi, the 3 most common causes being SAH, meningitis, and carcinoma 2 meningitis. Non-obstructive. This is sort of a trick question, with the only answer being something that produces CSF. The only answer you need to know is choroid plexus papilloma, discussed in detail in the tumor section. Quiz. LS transpendymal flow seem more with acute hydrocephalus or chronic hydrocephalus. Answer. Acute. 138. Edema. Cytotoxic. This type of edema can be thought about as intracellular swelling, secondary to malfunction of the Na/K pump. It tends to favor the gray matter and looks like loss of the gray-white differentiation. This is classically seen with stroke or trauma and is why early signs of stroke involve loss of the GMWM interface. Vasogenic. This type of edema is extracellular, secondary to disruption of the blood-brain barrier. It looks like edema tracking through the white matter, which is less tightly packed than the gray matter. This is classically seen with tumor and infection. You can also see this type of edema as a late stage of cerebral ischemia. A response to steroids is characteristic of vasogenic edema. Dash a dash dash. Dash a dash a dash dash a dash a dash. Underscore. Underscore. Dash a dash a dash a dash. 139. Brain herniation. Subfalcine herniation. This is just a fancy way of saying midline shift, deviation of ipsilateral ventricle, and bowing of the falx. The trivia to know is that the ACA may be compressed and can result in infarct. Descending transdentorial herniation. The uncus and hippocampus herniated through the tentorial incisura. Effacement of the ipsilateral suprasellar cistern occurs first. Things to know. Perforating basilar artery branches get compressed, resulting in diuret hemorrhages, classically located in the midline at the pontomesencephalic junction. In reality, they can also affect cerebellar peduncles. CN3 gets compressed between the PCA and superior cerebellar artery causing ipsilateral pupil dilation and ptosis. Comohan's notch eye phenomenon, the midbrain on the tentorium forming an indentation. Indentation, notch, and the physical exam finding of ipsilateral hemiparesis, which neurologists call a false localizing sign. Of course, localization on physical exam is stupid in the age of MRI, but it gives neurologists a reason to carry a reflex hammer, and how can one fault them for that? That. Ascending transdentorial herniation. Think about this in the setting of a posterior fossa mass. The vermis will herniate upward through the tentorial incisura, often resulting in severe obstructive hydrocephalus. Things to know: the smile of the quadrigeminal cistern will be flattened or reversed. Spinning top is a buzzword for the appearance of the midbrain from bilateral compression along its posterior aspect. Severe hydrocephalus at the level of the aqueduct. Cerebellar tonsil herniation can be from severe herniation after downward transdentorial herniation. Alternatively, if in isolation you are thinking more along the lines of Chiari I equals 1 tonsil 5 mm, or both tonsils 3 mm. 140. Section 3. Neurodegenerative. Toxic metabolic. Pres, posterior reversible encephalopathy syndrome seen with hypertension or chemotherapy. Features include asymmetric cortical and subcortical white matter edema, usually in parietal and occipital regions. Pres does not restrict on diffusion, helps tell you it's not a stroke. Pres, T2/flare high signal. Radiation-induced demyelination, seen as T2 bright areas and atrophy corresponding to the is stupid in the age of MRI, but it gives neurologists a reason to carry a reflex hammer, and how can one fault them for that? Ascending transdentorial herniation. Think about this in the setting of a posterior fossa mass. The vermis will herniate upward through the tentorial incisura, often resulting in severe obstructive hydrocephalus. Things to know: the smile of the quadrigeminal cistern will be flattened or reversed. Spinning top is a buzzword for the appearance of the midbrain from bilateral compression along its posterior aspect. Severe hydrocephalus at the level of the aqueduct. Cerebellar tonsil herniation can be from severe herniation after downward transdentorial herniation. Alternatively, if in isolation you are thinking more along the lines of Chiari I equals 1 tonsil 5 mm, or both tonsils 3 mm. 140. Section 3. Neurodegenerative. Toxic metabolic. Pres, posterior reversible encephalopathy syndrome seen with hypertension or chemotherapy. Features include asymmetric cortical and subcortical white matter edema, usually in parietal and occipital regions. Pres does not restrict on diffusion, helps tell you it's not a stroke. Pres, T2/flare high signal. Radiation-induced demyelination, seen as T2 bright areas and atrophy corresponding to the radiation portal. Can be seen with hemosiderin deposition and mineralizing microangiopathy, calcifications involving the basal ganglia and subcortical white matter. Osmotic demyelination syndrome, CPM, seen with rapid correction of sodium, usually in In a drunk. Usually T2 bright in the central pons, spare. $140. 140. _ section 3. Neurodegenerative. Toxic metabolic. Metabolic. Pres, posterior reversible encephalopathy syndrome seen with hypertension or chemotherapy. Features include asymmetric cortical and subcortical white matter edema, usually in parietal and occipital regions. Pres does not restrict on diffusion, helps tell you it's not a stroke. Pres, T2. T2/flare high signal. Radiation. Radiation-induced demyelination, seen as T2 bright areas and atrophy corresponding to the radiation portal, can be seen with hemosiderin deposition and mineralizing microangiopathy, calcifications involving the basal ganglia, and subcortical white matter. Osmotic demyelination syndrome, CPM, seen with rapid correction of sodium, usually in a drunk. Usually T2 bright in the central pons, spares the periphery. Can also have an extrapontine presentation in _140. Section 3. Neurodegenerative. Toxic metabolic. Pres, posterior reversible encephalopathy syndrome seen with hypertension or chemotherapy. Features include asymmetric asymmetric cortical and subcortical white white matter edema, usually in parietal and occipital regions. Pres does not restrict on diffusion, helps tell you it's not a stroke. Pres T2/flare high signal. Radiation-induced demyelination, seen as T2 bright areas and atrophy corresponding to the radiation portal. Portal. Can be seen with hemosiderin deposition and mineralizing microangiopathy, calcifications involving the basal ganglia and subcortical white matter. Osmotic demyelination. Demyelination syndrome, CPM seen, with rapid correction of sodium, usually in a drunk. Drunk. Usually T2 bright in the central pons, spares the periphery. Can also have an extrapontine presentation involving the basal ganglia, external capsule, amygdala, and cerebellum. CPM, T2 bright central pons. Wernicke encephalopathy, caused by thiamine deficiency. Just think contrast enhancement of the mammillary bodies, seen more in alcoholics. Additionally, think increased T2/flare signal in the bilateral medial thalamus and periaqueductal gray. Wernicke high signal in medial thalamus and periaqueductal gray. 141. 141. CNS findings secondary to drugs or toxins. Carbon monoxide, CT hypodensity IT2 bright globus pallidus, carbon monoxide causes globus warming. Alcohol, brain atrophy, especially the cerebellar vermis. Marcia favignami, seen in drunks. Swelling and T2 bright signal affecting the corpus callosum, typically beginning in the body, then genu, and lastly splenium. Will involve the central fibers and spare the dorsal and ventral fibers, called a sandwich sign, on sagittal imaging. Marcia favignami, high T2/flare in the corpus callosum. Methanol, optic nerve atrophy, hemorrhagic. Hemorrhagic putaminal and subcortical white matter. Matter necrosis. Post-radiation. Post-radiation. Post-radiation, there is a latent period. So imaging findings don't typically show up for about 2 months post-therapy. Whole brain radiation changes are typically T2 bright in the periventricular white matter, sparing the subcortical regions early on. Peripheral extension to the subcortical regions occurs later. Localized radiation, usually we are talking about severe focal edema with mass effect and enhancement. Differentiation from residual tumor can be a sneaky thing, and Mr. Perfusion may be useful in differentiating. Post-chemotherapy, you will have T2 effects acutely in the white matter that can progress to atrophy. Enhancement or mass effect is rare unless it is very severe. Children receiving both radiation and chemotherapy can sometimes develop calcifications, mineralizing microangiopathy. Disseminated necrotizing leukoencephalopathy, severe white matter changes, which demonstrate ring enhancement, classically seen with leukemia patients undergoing radiation and chemotherapy. This is bad news and can be fatal. 142. L. Neurodegeneration. Neurodegenerative disorders. You can do dementia imaging with a variety of imaging modalities, including CT and MRJ for structure, and FDG PET and SPECT for function. Pearl, on FDG PET the motor strip is always preserved in dementia. Preserved motor strip seen in degenerative dementias. Alzheimer's disease, most common cause of dementia. Most likely question is hippocampal atrophy, which is first, and out of proportion to the rest of the brain atrophy. They could ask temporal horn atrophy, 3 mm. (3 mm), which is seen in more than 65% of cases. Cases. Multi-infarct dementia. This is the second most common cause of dementia. Cortical infarcts and lacunar infarcts are seen on MRI. Most likely to be shown as a PET fog case, demonstrating multiple scattered areas of decreased activity. Cross-cerebellar diaschisis, CCD. CCD depressed blood flow and metabolism affecting the cerebellar hemisphere after a contralateral supratentorial insult, infarct, tumor resection, radiation. Creates an ant mini appearance, cross-cerebellar diaschisis. Dementia with With Lewy bodies, THLS is the third most common cause of dementia, second most common neurodegenerative, with a very similar clinical picture to the dementia seen with Parkinson's, with the major difference being that in DLB, the dementia comes first. The hippocampi remain normal in size, and you have some decreased FDG uptake in the lateral occipital cortex, with sparing of the mid-posterior cingulate gyrus, cingulate island sign. Binswanger disease, this is a subcortical leukoencephalopathy that affects older people, 55 and up, strongly associated with HTN. It's basically a form of small vessel vascular dementia. It classically spares the subcortical U fibers. See page 146 for an explanation on WTF U fibers are. 143. Alzheimer. Multi-infarct. Dementia with Lewy bodies. PICS I frontotemporal eye depression Hewiting-Toos. Fog PET, brain low posterior temporoparietal cortical activity scattered areas of decreased activity low in lateral occipital cortex. Low frontal lobe. Low activity in caudate nucleus and putamen. Identical to Parkinson dementia. Lyme, HIV, and vasculitis are mimics. Preservation of the mid-posterior cingulate gyrus, single TE island sign, depression is a mimic. 144. Section 4 infections. My idea for discussing intracranial infections is to think of a few testable scenarios. The neonatal infections, the infections related to HIV, the characteristic infections, and lastly meningitis and cerebral abscess. Neonatal infections. We are talking about torch infections. The first critical thing is that they only really matter in the first 2 trimesters, doesn't cause as much harm in the 3rd trimester. Calcifications and microcephaly are basically present in all of them. Here are some high-yield points regarding the torch infections. CMV, this is the most common torch by far, it's 3x more common than toxo, which is the second most common. It likes to affect the germinal matrix and causes periventricular tissue necrosis. The result is the most likely test question equals periventricular calcifications. Another high-yield piece of trivia is that of all the torches CMV has the highest association with polymicrogyria. Toxoplasmosis, this is the second most common torch. It's seen in the children of women who clean up cat shit. The calcification pattern is more random and affects the basal ganglia, like most other torch infections. The frequency is increased in the 3rd trimester, but only causes a problem in the first 2. The most likely test question equals hydrocephalus. Rubella, less common because of vaccines. Calcifications are less common than in other torches. On MR, focal high T2 signal might be seen in white matter related to vasculopathy and ischemic injury. HSV, as a point of trivia, it's usually HSV, 2 in 90% of cases. Unlike adults, the virus does not primarily affect the limbic system, but instead affects the endothelial cells resulting in thrombus and hemorrhagic infarction with resulting encephalomalacia and atrophy. HIV, this is not a torch but does occur during pregnancy, at delivery, or through breastfeeding. Brain atrophy predominantly in the frontal lobes is the main testable piece of trivia. You may also have faint basal ganglia enhancement seen on CT and MRI preceding the appearance of basal ganglia calcification. CNS torch, what you need to remember. CMV equals most common. Paraventric, ulnar calcifications, polymicrogyria. Toxo equals hydrocephalus, basal ganglia calcifications, rubella equals vasculopathy, ischemia. IL-I T2 signal, less calcifications. HSV hemorrhagic infarct, and lead low had encepha/omalacia, hydranencephaly. HIV equals brain atrophy in frontal lobes. 145. Infections immunosuppressed patients get people with AIDS. The most common opportunistic infection in patients with AIDS is toxo. The most common fungal infection in people with AIDS is cryptococcus. 2 other infections worth talking about are JC virus and CMV. HIV encephalitis, I'll lead with the encephalitis that people with AIDS get. This is actually pretty common and affects about 50% of AIDS patients. Usually we are talking about a situation with a CD4-200. What you are going to see is symmetric increased T2I flare signal in the deep white matter. TL will be normal. The lesions will not enhance. There may be associated brain atrophy. These tend to spare the subcortical U fibers, PML will involve them. Progressive multifocal leukoencephalopathy, PML, this is caused by the JC virus. We are talking about a situation with a CD4 less than 50. The imaging manifestations are single or multiple scattered hypodensities, with corresponding TL hypointensity. Remember HIV was TL normal, and T2/flare hyperintensities out of proportion to mass effect buzzword. The lesions have predilections for the subcortical U fibers. The asymmetry of these lesions helps differentiate them from HIV. WTF are these U fibers? They arc the fibers under the cortex. That look J-E-U-S. They come up a lot. As being spared or not spared. HIV encephalitis PML symmetric, and spare cortical U fibers asymmetric, and involves cortical U fibers. CMV, think about brain atrophy, cariventricular hypodensities, that are T2/flare bright, and ependymal enhancement. Cryptococcus, the most common fungal infection in AIDS. The most common presentation is meningitis that involves the base of the brain, leptomeningeal enhancement. The most likely way this will be shown on a multiple-choice exam is dilated perivascular spaces filled with mucoid gelatinous crap. These will not enhance. The second most likely way this will be shown is lesions in the basal ganglia, cryptococcomas. These are TL dark, T2 bright, and may ring enhance. 146. Toxo, most common opportunistic infection in AIDS. Classically we are talking about TL dark, T2 bright, ring enhancing, when larger than LCM, lesions. These guys will not show restricted diffusion. Just think ring enhancing lesion, with lots of edema. Most likely test question is that toxo is thallium cold, and lymphoma is thallium hot. Toxo, ring enhancing. Lots of edema. Not restricted. WTF. Hall abscesses rest jerichal diffusion. Typical abscesses do. Ilokfker, atypical infections like toxo or fungal don't always do this, and showing that it does not restrict might be a sneaky way to test this. Toxolymphoma ring enhancing hemorrhage more common, alter treatment hemorrhage less common, after treatment thallium cold pet cold Mr. perfusion, decreased CBV. Summary. AIDS PML encephalitis symmetric T2 asymmetric T2 bright. MRI gamesmanship, enhancement patterns. In general, to solve MR puzzles you will need to be able to work through some Mr. sequences. The trick is to have a list of things that are TL bright, T2 bright, restrict diffusion, and enhance. Plus you should know the basic enhancement patterns, homogeneous, heterogeneous, ring, and incomplete ring. Stroke vs tumor vs abscess vs MS plaque. T2. For the most part, T2 is not helpful for lesion characterization, as tumors, stroke, MS, infections all have edema. DWI, this is helpful only if they follow the classic rules. Out of those four, tumor, abscess, MS, and stroke, the classical diffusion restrictors are abscess and stroke. Certain hypercellular tumors, classically lymphoma, can restrict, and demyelinating lesions with acute features can restrict. Enhancement. In this situation, this is probably the most helpful. Out of those four, tumor, abscess, MS, and stroke, each should have a different pattern. Tumor could be heterogeneous or homogeneous if high grade, or none if low grade. Abscess will classically have ring pattern. MS will classically have an incomplete ring pattern. Stroke will have cortical ribbon, gyriform, type enhancement in the subacute time period, around 1 week. Heterogeneous, most likely tumor, higher grade. Ring can be lots of stuff, abscess and tumor are both prime suspects. Incomplete ring, classic 4. Skill, demyelinating. Gyriform, classic for subacute stroke. Stroke can also be seen with pres or encephalopathy I encephalitis. 148. The characteristic infections. TB meningitis. TB meningitis looks just like regular meningitis, except that it has a predilection for the basal cisterns, and may have dystrophic calcifications. There may be enhancement of the basilar meninges with minimal nodularity. Complications include vasculitis, which may result in infarct, more common in children. Obstructive hydrocephalus is common. Most likely way to show this is enhancement of the basilar meninges. Sarcoid can do that too, so it won't be a distractor unless he/she also has hydrocephalus, in which case pick TB. HSY, LT's HSV1 in adults and HSY2 in neonates. I mentioned that because 1, it seems like testable trivia, and 2, they actually have different imaging appearances, as mentioned above. Type 2 doesn't love the limbic like type 1. For the purpose of multiple choice test, you are going to have a swollen, unilateral or bilateral, medial temporal lobe, which will be T2 bright. Earliest sign is actually restricted diffusion, related to vasogenic edema. This could be tested by asking what sequence is more sensitive, with the answer being the diffusion is more sensitive than T2. Blooming on gradient means it's bleeding, common in adults, rare in neonate form. Other trivia is that it spares the basal ganglia, distinguishes it from MCA stroke. Herpes edema in the temporal lobe. Limbic encephalitis, not an infection, but a commonly tested mimic. It is a paraneoplastic syndrome, usually small cell lung cancer, that looks very similar to HSV. This could be asked by showing a classic HSV image, but then saying HSV titer negative. The second order question would be to ask for lung cancer screening. West Nile. Several viruses characteristically involve the basal ganglia, Japanese encephalitis, Murray Valley fever, West Nile. The only one realistically testable is West Nile. We are talking about T2 bright basal ganglia and thalamus, with corresponding restricted diffusion. Hemorrhage is sometimes seen. 149. CJD, there are 3 types, sporadic, 80 to 90%, variant, rare, and familial, 10%. Random factoid is that it has a characteristic appearance on EEG, and this 14-3-3 protein assay is a CSF test neurologist's order. The imaging features are variable and can be unilateral, bilateral, symmetric, or asymmetric. I want to concentrate on the most likely testable appearances, of which I think there are 3. 1. DWI showing cortical gyriform restricted signal, supposedly diffusion, is the most sensitive sign, and the cortex is the most common early site of manifestation. 2. Hockey stick sign I pulvinar sign, restricted diffusion in the dorsal medial thalamus, which looks like a hockey stick, or in the pulvinar. 3. A series of MRs or CTS showing rapidly progressive atrophy. CJD, gyriform restricted diffusion. Neurocysticercosis, caused by eating pig shit, or undercooked pork. The bug is Tinea solium. The most common locations of involvement are the subarachnoid space over the cerebral hemispheres, basal cisterns, brain CJD, there are three types: sporadic, 80 to 90%, variant, rare, and familial, 10%. Random factoid is that it has a characteristic appearance on EEG, and this 14-3-3 protein assay is a CSF test neurologist's order. The imaging features are variable and can be unilateral, bilateral, symmetric, or asymmetric. I want to concentrate on the most likely testable appearances, of which I think there are three. 1. DWI showing cortical gyriform restricted signal, supposedly diffusion, is the most sensitive sign, and the cortex is the most common early site of manifestation. 2. Hockey stick sign, Pulvinar sign, restricted diffusion in the dorsal medial thalamus, which looks like a hockey stick, or in the pulvinar. 3. A series of MRs or CTS showing rapidly progressive atrophy. CJD. CJD, gyriform restricted diffusion. Neurocysticercosis, caused by eating pig shit or undercooked pork. The bug is Tinea solium. The most common locations of involvement are the subarachnoid space over the cerebral hemispheres, basal cisterns, brain parenchyma, and ventricles in that descending order. As a point of trivia, involvement of the basal cisterns carries the worst outcome. It has 4 stages which could be written in the form of a multiple-choice questions that would be really dirty and therefore likely. Vesicular, thin-walled cyst, ISO-TLM and no edema, colloidal, hyperdense cyst, bright TL/T2 plus edema, granular, cyst shrinks, wall thickens, less edema, nodular small calcified lesion, no edema. 150. L meningitis and cerebral abscess. You can think of meningitis in 4 main categories: bacterial, acute pyogenic, viral, lymphocytic, chronic, TB or fungal, and non-infectious sarcoid. Essentially, we are talking about thick leptomeningeal enhancement in the appropriate clinical setting. The complications are numerous and include venous thrombosis, vasospasm, leading to the stroke, empyema, ventriculitis, hydrocephalus, abscess, etc., and so on and so forth. Abscess facts, trivia: DWI, restricts MRS lactate high PET FDG increased metabolic. A VE1Y testable piece trivia is that infants will often get sterile reactive subdurals, much less common than in adults. Empyema can be subdural or epidural, just like blood. Follows the same rules as far as crossing dural attachments, epidurals don't, and crossing the falx, subdurals don't. Subdurals are more common and have more complications relative to epidurals. The vast majority of subdurals are the sequela of frontal sinusitis. The same is true of epidurals, with some sources claiming 2/3 of epidurals are secondary to sinusitis. They are often TL bright and can restrict on diffusion. Subdural empyema, dural enhancement, restricts. Intraaxial infections, we are talking cerebritis, abscess, and ventriculitis. Again, lots of causes via direct spread, or hematogenous spread. The causes worth thinking about include right to left shunts, and pulmonary AVMs. Cerebritis is the early form of intraaxial infection, which can lead to abscess if not treated. Ventriculitis, usually the result of a shunt placement or intrathecal chemo. Chemo. The ventricle will enhance, and you can sometimes see ventricular fluid levels. If septa start to develop, you can end up with obstructive patterns of hydrocephalus. The intraventricular extension of abscess is a very serious ominous preterminal event. 151. SEC110. SEC110NS, brain tumors. The Promethean method. I want to introduce my idea for brain tumor diagnosis. The strategy is as follows. 1. Decide if it's single or multiple. 2. Look at the age of the patient. Adults and kids have different differentials. 3. Look at the location. Different tumors occur in different spots. 4. Now use the characteristics to separate them. The strategy centers around narrowing the differential based off age and location till you are only dealing with 3 for common things, then using the imaging characteristics to separate them. It's so much easier to do it that way. Multifocal primary from seeding multiple masses syndromes, example NF2. Cortical. Ultraventricular. Adult ____. CP angle single mass / infratentorial kid. Supratentorial. Skull base I dura. Sella I paracella. Pineal gland. Before we get rolling, the first thing to do is to ask yourself, is this a tumor, or is it a mimic? Mimics would be abscess, infarct, or a big MS plaque. This can be tricky. If you see an incomplete ring, you should think giant MS plaque. If they show you diffusion, it is either lymphoma, or a stroke, or an abscess. You'll need to use enhancement to straighten that out. Remember, lymphoma enhances homogeneously. 152. L. 2 more high-yield topics before we start crushing the differentials. Intraaxial vs. extraaxial. The Brandt and Helms discussion on brain tumors will have you asking intraaxial vs. extraaxial first. This is not always that simple, but it docs lend itself very well to multiple choice test questions, therefore it's high yield. Basically, you need to memorize the signs of extraaxial location. CSF cleft displaced subarachnoid vessels, cortical gray matter between the mass, and white matter displaced and expanded subarachnoid spaces, broad dural base, I-tail bony reaction. Why do things enhance? Understanding the why is very helpful for problem solving. Let me first answer the question. Question: why don't things enhance? They don't enhance because of the blood-brain barrier. So when things do enhance, it's because either A, they are outside the blood-brain barrier, they are extraaxial, or B, because they have melted the blood-brain barrier. In other words, extraaxial things, classic example is the meningioma, will enhance. High-grade tumors and infections enhance. Low-grade tumors just aren't nasty enough to take the blood-brain barrier down. Are there exceptions? HA. There always are. And yes, they are always testable. Gangliogliomas and pilocytic astrocytomas are the exceptions. They are low-grade tumors, but they enhance. 153. Multiple masses. In adults or kids, if you see multiple masses, you are dealing with Mets or infection. Differentiating between Between Mets and infection is gonna be done with diffusion, infection will restrict. If they want you to decide between those two, they must show you the diffusion, otherwise only one, or the other will be listed as a choice. Trivia on Mets. Most common CNS Met in a kid equals neuroblastoma, bones, dura, orbit, not brain. Most common location for Mets equals supratentorial at the gray-white junction. This area has a lot of blood flow plus an abrupt vessel caliber change, so you also see hematogenous infection. Aseptic emboli go there first too. Most common morphology is round or spherical. Remember that Mets do not have to be multiple. In fact, 50% of Mets are solitary. In an adult, a solitary mass is much more likely to be a Met than a primary CNS neoplasm. MRCT in the mnemonic for bleeding Mets: melanoma, renal, carcinoid, choriocarcinoma, thyroid. Usually Mets have more surrounding edema than primary neoplasms of similar size. Next step, gamesmanship, because the most common intraaxial mass in an adult is a Met. If they show you a solitary mass or multiple masses, and want a next step, it's gonna be go hunting for the primary, think lung, breast, colon, the common stuff. What about a multifocal primary brain tumor? Can that happen? Oh yeah, there are a few that like to do that. You should still think Met first. Tumors that like to be mu/focal, lymphoma, multicentric GBM, gliomatoses cerebri, tumors that are multifocus/ from seeding, medulloblastoma, ependymoma, GBM, oligodendroglioma syndromes. Tumors with syndromes are more likely to be multifocal. NFL, NF2, MSME, tuberous sclerosis, VHL, optic GI, iomas, multiple schwannomas, subependymal hemangioblastomas, tubers. L. Cortically based, PDOG. Most intraaxial tumors are located in the white matter. So when a tumor spreads to or is primarily located in the gray matter, you get a shorter DDX. High-yield piece of trivia regarding the cortical tumor, cortical Met, is that they often have very little edema, and so a small cortical Met can be occult without for contrast. PDOG. Pleomorphic xanthoastrocytoma, PXA. Decembryoplastic neuroepithelial tumor, DNET. Oligodendroglioma. Ganglioglioma. Oligodendroglioma, remember this is the guy that calcifies 90% of the time. It's most common in the frontal lobe, and the buzzword is expands the cortex. This takes after its most specific feature of cortical infiltration and mark thickening. It's likely you could get asked about this LP/19q deletion, which apparently has a better outcome. Ganglioglioma, this guy can occur at any age, anywhere, and look like anything. However, for the purpose of multiple choice testing, the classic scenario would be a 13-year-old with seizures, and a temporal lobe mass that is cystic and solid with focal calcifications. There may be overlying bony remodeling. DNET, decembryoplastic neuroepithelial tumor, kid with drug-resistant seizures. The mass will always be in the temporal lobe. On the test, real life 60% temporal. Focal cortical dysplasia is seen in 80% of the cases. It is hypodense on CT, and on MRI there will be little if any surrounding edema. High T2 signal, bubbly lesion. PXA, pleomorphic xanthoastrocytoma, superficial tumor that is always supratentorial and usually involves the temporal lobe. They are often in the cyst with a nodule category, 50%. There is usually no peritumoral T2 signal. The tumor frequently invades the leptomeninges. Looks just like a desmoplastic infantile ganglioglioma, but is not in an infant. Dash a dash a dash dash a dash a dash a dash dash a dash a dash dash Dash. Interventricular. Tumors can arise from the ventricular wall, septum pellucidum, or choroid plexus. Dash dash a dash dash dash. Dash 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 a dash a dash 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 a dash 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 1 a dash dash a dash dash. Dash dash a dash 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 a dash. Dash a dash dash. Dash dash. Medulloblastoma. Let's just assume we are talking about the classic medulloblastoma, which is a type of peanut. If you want to understand the genetic spectrum of these things, read Osborne's Brain, but that's probably overkill. This is a pediatric tumor, with most occurring before age 10. Technically there is a second peak at 20 to 40, but for the purpose of multiple choice tests, I'm going to ignore it. These guys are cerebellar, arise from vermis, project into fourth ventricle, tumors that love to met via CSF pathways. The mass is heterogeneous on T1 and T2, and enhances homogeneously. They are much more common than their chief differential consideration, the ependymoma. They are hypercellular and may restrict. They calcify 20% of the time, less than ependymoma. As mentioned above, they like to drop met. The buzzword is Zuckerguss, which apparently is German for sugar icing, as seen on post-contrast imaging of the brain and spinal cord. As a point of absolute trivia, they are associated with basal cell nevus syndrome and Tickett syndrome. Gorlin syndrome, Alphiacea medulloblastoma. Next, look for dural calx. If you see thick dural calx, you might be dealing with this syndrome. They get basal cell skin cancer after radiation and have odontogenic cysts. Next step trivia. Preoperative imaging of the entire spinal axis should be done in any child with a posterior fossa neoplasm, especially if medulloblastoma or ependymoma is suspected. Evidence of tumor spread is a statistically significant predictor of outcome. Medulloblastoma, ependymoma more common, less common, originate from vermis I roof of th. Subependymal giant cell astrocytoma, SEGA. This is going to be shown in the setting of TS. They will more than likely show you renal AMLs or tell you the kid has seizures, a developmental delay. Because it's syndromic, you see it in kids, average age 11. It will arise from the wall of the lateral wall of the ventricle, near the foramen of Monro, often causing hydrocephalus. It enhances homogeneously. This vs that, SEGA vs subependymal nodule, SEN, the SEN. SEN will stay stable in size, the SEGA will grow. The SEGA is found in the lateral ventricle near the foramen of Monro. The SEN can occur anywhere along the ventricle. SENs are way more common. Both SEN and SEGA can calcify. Pearl enhancing, partially calcified lesion at the foramen of Monro bigger than 5 mm is a SEGA, not a SEN. The next two for tumors are in adults. Subependymoma, found in adults. Well circumscribed for mass, most commonly at the foramen of Monro and the fourth ventricle. They can cause hydrocephalus. They typically don't enhance. They are T2 bright, like most tumors. Central neurocytoma. Neurocytoma. This is the most common for mass in an adult aged 20 to 40. The buzzword is Swiss cheese because of the numerous cystic spaces on T2. They calcify a lot, almost like oligodendrogliomas. Central neurocytoma, 2 examples, 1 cystic for mass. 158. L. Choroid plexus origin. Choroid plexus papilloma I carcinoma can occur in peds, 85% under the age of 5, or adults. They make up about 15% of brain tumors in kids under 1. Basically, you are dealing with an intraventricular mass, which is often making CSF, so it causes hydrocephalus. Here is the trick: brain tumors are usually supratentorial in adults and posterior fossa in kids. This tumor is an exception. Remember, exceptions to rules are highly testable. Trivia. In adults it's in the 41 ventricle, in kids it's in the lateral ventricle, usually trigone. Carcinoma type is only seen in kids, and are therefore basically only seen in lateral ventricle I trigone. Carcinoma association with Li-Fraumeni syndrome, bad P53. Angiography may show enlarged choroidal arteries which shunt blood to the tumor. Carcinoma type of these tumor looks very similar, unless it's invading the parenchyma, and is almost exclusively seen in kids. The tumor is typically solitary, but rarely you can have CSF dissemination. Xanthogranuloma, this is a benign choroid plexus mass. You see it all the time, 7%, and don't even notice it. The trick is that they restrict on diffusion, so they are trying to trick you into working them up. They are benign, leave them alone. Xanthogranuloma, note the restricted diffusion. 159. Miscellaneous. METs, the most common location of intraventricular metastasis, is the trigone of lateral ventricles, because of the vascular supply of the choroid. The most common primary is controversial, and either lung or renal. If forced to pick, I'd go lung because it's more common overall. I think all things equal renal goes more, but there are less renal cancers. It all depends on how the question is worded. Colloid cyst, these are found almost exclusively in the anterior part of the third ventricle behind the foramen of Monro. They can cause sudden death via acute onset hydrocephalus. Their appearance is somewhat variable and depends on what they are made of. If they have cholesterol, they will be TL bright, T2 dark. If they don't, they can be T2 bright. 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 The trick is around well-circumscribed Circumscribed mass in the anterior third ventricle. Ventricle. If shown on CT, it will be pretty dense. Cohoid cyst, anterior third ventricle, hyperdense on CT. Meningioma can occur in an intraventricular location, most commonly 80%, at the trigone of the lateral ventricles, slightly more on the left. Details on meningiomas are discussed below. 160. L. Cerebellar pontine angle, CPA. Age is actually less of an issue here because the DDX isn't that big. Most of these are adult tumors, but in the setting of NF2 you could have earlier onset. Epidemiology, vestibular schwannoma is number 1, making up 75% of the CPA masses, number 2 is the meningioma making up by 0%, and the epidermoid is number 3 making up about 5%. The rest are uncommon. Vestibular schwannoma, these guys account for 75% of CPA masses. When they are bilateral you should immediately think NF2, 1 for each side. Enhances strongly but more heterogeneous than meningomas. May widen the pons acousticus resulting in a trumpet-shaped IAC. Meningioma. Meningioma. Enhance homogeneously, don't usually invade IAC. Schwannoma. Enhance less homogeneously, invade IAC. Meningioma, second more common CPA mass. Mass. One of the few brain tumors that is more common in women. They can calcify, and if you are lucky they will have a dural tail, which is pretty close to pathognomonic, with a few rare exceptions. Because they are extradural they will enhance strongly. Radiation of the head is known to cause meningiomas. Calcify more often IAC can have. Trivia. Most common location of a meningioma is over the cerebral convexity. Trumpeted appearance. They take up octreotide and TCMDP on nuclear medicine tests. Sneaky. Epidermoid can be congenital or acquired after trauma, classically after LP in the spine. Unlike dermoids they are usually off midline. Midline. They will follow CSF density and intensity on CT and MRI, the exception is this zebra called a white epidermoid. Epidermoid, which is TL bright, just forget I ever mentioned it. The key points are I, unlike an arachnoid cyst they are bright on flare, sometimes warm, they dawn I completely null, and 2, they will restrict with diffusion. Epidermoid, follows CSF signal, restricts diffusion. Dermoid cyst, this is about 4x less common than an epidermoid. It's more common in kids young adults. Usually midline, and usually are found in the 3rd decade. They contain lipoid material, and are usually hypodense on CT, and very bright on TL. They are associated with NF2. Trivia. These are usually midline. Most common location for a dermoid cyst is the suprasellar cistern, posterior fossa is number 2. This vs that, dermoid vs epidermoid. The easy way to think of this is that the epidermoid behaves like CSF, and the dermoid behaves like fat. IAC lipoma, it can occur, and is basically the only reason you get a T1 when you are working up CPA masses. It will fat SAT out because it's a lipoma. There is an association with sensorineural hearing loss, as the vestibulocochlear nerve often courses through it. Arachnoid cyst, common benign lesion that is located within the subarachnoid space and contains CSF. They are increased in frequency in mucopolysaccharidoses, as are peravascular spaces. They are dark on flare, like CSF, and will not restrict with diffusion. How can you tell an epidermoid from an arachnoid cyst? Cyst. The epidermoid restricts, the arachnoid cyst does not. 162. L. Infratentorial, most are PEDs, hemangioblastoma is the exception. Atypical teratoma, rhabdoid, these are highly malignant tumors, HUTV, and rarely occur in patients older than 6 years. The average age is actually 2 years, but they certainly occur in the first year of life. They can occur in supra- and infratentorial locations, most common in the cerebellum. These are usually large, pissed-off-looking tumors with necrosis and heterogeneous enhancement. Years, but they certainly occur in the first year of life. They can occur in supra- and infratentorial locations, most common in the cerebellum. These are usually large, pissed-off-looking tumors with necrosis and heterogeneous enhancement. Juvenile pilocytic astrocytoma, JPA, just think cyst with a nodule in a kid. They are WHO grade 1, but the nodule will still enhance. This will be dermoid cyst. This is about 4x less common than an epidermoid. It's more common in kids and young adults. Usually midline, and usually are found in the third decade. They contain lipoid material, and are usually hypodense on CT, and very bright on TL. They are associated with NF2. Trivia. These are usually midline. Most common location for a dermoid cyst is the suprasellar cistern. Posterior fossa is number 2. This vs that, dermoid vs epidermoid. The easy way to think of this is that the epidermoid behaves like CSF, and the dermoid behaves like fat. IAC lipoma, it can occur, and is basically the only reason you get a T1 when you are working up CPA masses. It will fat SAT out because it's a lipoma. There is an association with sensorineural hearing loss, as the vestibulocochlear nerve often courses through it. Arachnoid cyst, common benign lesion that is located within the subarachnoid space and contains CSF. They are increased in frequency in mucopolysaccharidosis, as are peravascular spaces. They are dark on flare, like CSF, and will not restrict with diffusion. How can you tell an epidermoid from an